Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Good morning. I'm Timothy Craig. Welcome. I'm sitting in Hanoi. Have poor control of my light, but I should say, I guess, good morning, America. So this talk is patient-centered approaches to long-term prophylaxis and hereditary angioedema. I'm Timothy Craig. I'm a tenured professor of medicine, pediatrics, and biomedical sciences at Penn State University. I run the International Center for HAE there. And I'm really pleased to introduce Marc, who is going to be talking about mainly therapy over the last part of this discussion. And Marc is professor of medicine. He's at University of California, San Diego, and he's the clinical director of the US HAE Angioedema Center, which is just within San Diego itself. So welcome, Marc.
Thanks, Tim.
So the learning objectives are first to identify barriers in care of people who have HAE. And that's very important because still in the United States and definitely around the world, people are not being diagnosed with HAE and thus are not getting therapies they deserve. We also want to apply the existing recommendations from the guidelines, and I'll be doing that as well as Marc when he talks about therapy. We'll be talking a little about pathophysiology, and we'll talk about strategies to hoping to ensure that people get therapies, again, that they deserve since they have a rare disease. So again, I'm going to focus on making a diagnosis, and then most of what I talk about will be dealing with that issue, and then Marc will talk about the therapies, and towards the end, he'll talk about those therapies and research, which are really stunning, and how many drugs we have that hopefully will be approved in the next few years. So I always like to start with this, is because in 25 years of therapy, the majority of the time was actually, I should say, in 25 years of studying therapy in this field, most of the time was really making this woman a person who, after treatment, would become this woman. So it would be treating the acute symptoms and so on. But now I think we're finally at that case. I'm having a problem advancing. Okay. We're finally at that time where we have therapies where this young lady really can feel pretty secure that she's not going to have an attack. She can go to camp, she can go to school, and just about do anything she wishes to do. She'll always need to carry rescue medication, but I think we are at that point of making her feel like this, where she can join her friends, go out and really have some control of her surroundings and her disease, and feel that she is part of the other people in her life. So as you know, HAE is a rare genetic disease. They estimate about 6,000 to 10,000 in the United States. That's based on a data from Denmark, which shows about 1 in 50,000 people have HAE. It is a disease that episodic, and not everybody who has the genetic abnormality nor the deficiency of protein will have symptoms. But the symptoms also varies considerably from maybe just rare once a year to having many attacks per month. It does attack the GI tract, any skin surface. The genitalia can also be attacked. And the thing we all dread, but luckily so, it's not the majority of attacks, is the upper airway. And thankfully so, that's rare, 1% to 3%. But once a person has it, it can make a radical change in their life from then on. Most cases start early in life, within the first 2 decades of life. It tends to be puberty that defines the severity of people for later on in their life. But it's not unusual to have people who are very, very young and have symptoms. And I would have a case that I'll talk about in a second. Now, I just wanted with this slide just point out that mainly we'll be talking about HAE1 and HAE2. Now, if you look over to the right, what we used to call HAE3 is now HAE with normal C1 inhibitor. Unfortunately, there's not one diagnosis here, there's many. And Thankfully so in the United States, we can get genetic testing now for most of these. And actually, some of these don't even use bradykinin as their source of edema. So because there's no clinical studies on this or clinical therapeutic studies for normal C1 inhibitor patients, we're really not going to address that today. That is very unfortunate. These people are desperate for good therapies. I think what we have to do is change our nomenclature, which is what's happening right now, so that we look at just one of these at a time and do research on one genetic abnormality leading to one protein abnormality so we can find the best therapies possible for these individuals. So I'm going to leave normal people behind right now with some rare exceptions. So what do we see here? Well, if you look at the hand to the right here, you see swelling. If it's minimal swelling, it may not be painful. This person, the amount of swelling you see is pretty gross, and that I'm sure that's very painful, is stretching the skin and so on. But what you don't see is hives. You don't see erythema. You can sometimes, depending on the area, have a little bit of erythema, but it's not like histamine-induced disease. Like I said, it can affect any skin surface. It can be a right foot and a left hand and a face all at once, or it can be just one. It's not accompanied by urticaria. But if you look to the lower right, that slide, the erythema marginatum, a lot of people confuse that with urticaria. I have one lady I did a film with, and she says, I get urticaria all the time. I've had it my whole life. Look. And it wasn't urticaria. It's actually erythema marginatum that she's been having her whole life. The thing is that there are rare individuals who could have both urticaria, though, and hereditary angioedema just by chance alone. But that is not a usual event. They tend to have non-itchy lesions when they do get swelling, and it can occur in any position. It's not pitting like it is in edema from congestive heart failure. Again, it can attack the upper airway, which is dreadful. It can attack the GI tract. And in fact, in most cases, in at least the cases I follow, that distribution between GI attacks and skin is about 50-50. Now, about 75% of people will have a family history. In the United States, it's becoming more difficult since we move around so much. And also, it can skip a person in the family, right? So dad could have hereditary angioedema, but never have any symptoms, even though he has a genetic abnormality and a protein abnormality, where his son can have symptoms. So family history isn't always absolute. Plus, about 25% of people are thought to be new mutations. So again, they'll start their family line from that point on. If you look at the distribution, 85% are supposed to be type 1, 15% type 2, and you can see type 3 is supposed to be really minimal. But, there's just a recent paper where people thought that maybe 25% of their patients may be of a HAE with normal C1 inhibitor. Most of those people, the vast majority, were not genetically tested, nor proven to have a genetic abnormality. The problem is, though, a negative genetic abnormality does not exclude the disease. A positive one helps include the disease. So I think we still have a long ways to go with HAE with normal C1 inhibitor to really take care of these people as they deserve. So what triggers what triggers an attack? It can be varied. Everybody says anxiety. Sometimes I think the anxiety is actually because of the bradykinin itself, and there's mice models to show that. But whatever the case is, people often get anxious before their attacks. Any kind of trauma can cause attacks, or dental work, medical procedures, surgical work, infections of the upper airway. Never should you give ACE inhibitors to these people. When I say never, I really truly mean that with ACE inhibitors. With estrogen, I always said never, but now with transgender and so on, I guess you really can't say never. But I can tell you, I've tried to have people, because of reproductive problems, go on estrogen, females, and it was very difficult to have them maintained on estrogen. It's a big trigger for attacks. So the frequency, as I mentioned, varies considerably to none, to having many attacks per month. And, when you have an attack, it can last days, anywhere from 1 to 5 days. We usually use the number 3. So if you have an attack weekly and you have 3 days of attack, you can see how that would be a big problem with going to work, with being productive at work, going to school and learning, and doing, the social things that you and I like. So it really is a major obstacle to those people, especially those that have severe disease. So right now, I'd say one of the main limitations in diagnosis is actually recognition. I think Marc would agree. I think there's a lot of people who have HAE with normal C1 inhibitor that are misdiagnosed. But I think with type 1 and type 2, the major thing is that people are not diagnosed. And that has a lot to do with access to physicians who know the disease. Marc and a few other people looked at the rural environment. And I've looked at the city environment before, and in inner cities, just like in remote areas rurally, where there's not physicians who have expertise, those are the people that really suffer from HAE more than those who are in areas where there's good access to care. So what we look at is a couple of things when we're considering a diagnosis. You look at the family history, not always there, as I just mentioned. You look at the occurrence of abdominal symptoms, and you look at skin symptoms. You look at the absence of urticaria. You look at, especially if someone's had upper airway symptoms, and then you get some laboratory tests, which I'll talk about in a second. So these are the laboratory tests. So you can see HAE1, the serum C4 would be low. The protein C1 inhibitor, because there's a defect in producing it, is going to be low. And because the protein's low, the function of that protein is going to be low. So that's a pretty easy diagnosis by biochemical test when you're in the United States or Australia, Japan, Western Europe. But I can tell you in the rest of the world, you probably don't have the functional level to really make that diagnosis, unfortunately. And sometimes the only test people have is the C4 level, and that is not an absolute test. Between attacks, it's probably about 85% have a reduction. During attacks, I used to say 100% of people would have a low C4. However, I now have a patient who it changes, but it doesn't become fall into the normal range when they have an attack. Their C4 still stays up above normal. That's very rare, though. When you look at HAE2, here's where it's a little different, right? So here the C4 is going to be low, but the protein itself is either going to be normal and sometimes even elevated, because here the protein's made, the enzymatic head is dysfunctional. So the function will be low. So if you don't have a functional level, you could miss these people. And then, unfortunately, as I talked about, you have those HAE with normal C1 inhibitor. And these people really are very difficult to diagnose at times. They don't have a clear family history, and genetic testing is often necessary. And I'm not going to talk about the genetic testing at this time. Marc may want to, though. So the first interactive question is in suspected cases of HAE, persons with a decreased C4 level and C1 inhibitor function, as well as normal elevated C1 antigen levels, suggest what type of hereditary angioedema? Would it be type 1? Would it be type 2? Would it be what we used to call type 3, which is now normal C1 inhibitor hereditary angioedema? Or would it be none of the above? So the answer would be, it would be type 2 hereditary angioedema, right? So here the C4 is low. The protein is defective in the enzymatic head, so the protein is going to be there and maybe even elevated, but the function will be low. So again, this is looking at the testing for HAE. So you can see to the left here, you can see the C4, C1 inhibitor level and function are all low. There's 2 diagnoses that can cause this, right? Like I just talked about, type 1 hereditary angioedema. There's another diagnosis, though, is acquired angioedema. Now, this is slightly different, right? Usually in an older age group, but there have been reports of people very young having acquired angioedema. These people, too, will often have a low C1q, but that's not 100% of people. It's 75%. These people don't have a family history. But if you have a patient who you think has type 1 and they had their first attacks later in life, it's probably a good idea to exclude that they have acquired angioedema. and that is by getting a C1Q and doing a good history, a physical exam, and a good family history as well. These people are treated differently. Rituximab is usually their treatment of choice, and so it's really important to make that diagnosis since most of these people will have a low-grade lymphoma. You can see in the middle here, here's type 2, right? They have low C4, they have normal C1 inhibitor levels, but their function is off, and there's not much that mimics that. And then to the right, you have all these tested being normal. That could be a HAE with normal C1 inhibitor, or it could be a person with idiopathic angioedema, or it could be a person with histamine-induced angioedema. So this is one of my favorite slides. So what this shows is in the top panels, you can see the green and the pink. The pink is the nucleus, the green are tight junctions. To the right of that, you can see the nucleus is instead purple, and you can see red. That's tiny fibers of actin inside the cell. And what happens in HAE, if you have factor 12 activated, it activates kallikrein. Kallikrein then feeds back on to activate more factor 12. Factor 12, once it's activated, also feeds on itself. And then kallikrein is produced, which causes high molecular weight cholinegen to fragment, which becomes bradykinin that binds to the endothelial cells on the B2 bradykinin receptor. And what you see here, if you do have bradykinin, this top panel where you have nice tight junctions between the endothelial cells, you can see those tight junctions actually dissolve. And then you see here all these microtubules of actin in the bottom right, pulling the cell inward away from its colleagues around it. And you can see why with that loss of the tight junction and the cell contracting upon itself away from the partners around it, the fluid would shift from the vascular space into the interstitial space. Thankfully so, it doesn't become systemic. People would probably die of hypovolemia if that was the case. It tends to be limited, maybe because the half-life of bradykinin is so short, but there may be other reasons for that as well. Thank you for joining us in this episode of Patient-Centered Approaches to Long-Term Prophylaxis in Hereditary Angioedema. Please return to the landing page to access the episode 2 of this series.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.